checking the occlusion as part of your periodontal examination is a must. It's something which is often left, and it is really important and valid. Just because I don't feel it's the primary cause of periodontitis doesn't mean to say I find it any less important in progression of periodontitis. And it has to be addressed, especially when I show you those cases where they were in part exacerbated by a trauma from occlusion. If you don't treat the trauma from occlusion when it's exacerbated a periodontal problem, it's never going to be treated. So it's really important.
I am getting very nervous and very anxious. Why? Because it's been so many episodes since I talked about something occlusion related. So when this happens, I get very nervous. So let's focus back in. Let's pull it back into occlusion, can we? Today is all about perio and occlusion. I'm joined by my good friend, specialist periodontist, Richard Horwitz. And we're going to sort of do some myth busting or perhaps some changing of perceptions. Can occlusion cause perio? I was about to say, can perio cause occlusion? But that'd be stupid. Can occlusion, and what I mean by occlusion is, can someone with a dodgy bite, are they more susceptible to perio? Is that a thing? Like, occlusal trauma, we know that occlusal trauma exists, but what role does occlusion actually play in periodontal bone loss? So that's the kind of stuff we're covering today. So welcome everyone to episode 47 of the Protrusive Dental Podcast. Now, another massive thank you is due for everyone. Around about a month ago now, something pretty awesome happened. We crossed, and I say we because, you guys are like family to me now. A lot of you on the Protrusive Dental Community Facebook group, and I love seeing you guys there. We crossed 50,000 downloads, right? And this is pretty big, right? Okay, a lot of podcasts that get created. It's like businesses, like 9 out of 10 new businesses will fail in the next 5 years or something like that. It's a famous quote, right? So a lot of podcasts started and they never reached 50,000 downloads. And so I am so thankful to you all for giving up your time to listen in your commutes while you're chopping onions, while you're gardening, that sort of stuff. And, it's amazing. So thank you, community, which reminds me, I need to change your name and I need your help. If you can think of a better name for the good people who listen to the podcast from something else other than family or community, what would be a good name for you guys, right? Help me out. I'm going to post on the Protrusive Dental Podcast community Facebook group as well, and hopefully we can get some good ideas. You can Instagram me as well at Jazzy Gulati. But before we get to the episode, of course, I owe you a Protrusive Dental Pearl. This episode's Protrusive Dental Pearl is when you're doing anterior composites and you want to get a very nice contact point, which we all do, obviously. The choice is often twofold, okay? And this could also be applied to resin veneers. You could either do the mylar pull technique, or you can do, and I've talked about that once before, some episodes ago, like a little mini episode, but I want to focus in on the other technique, which is actually using a matrix band. And the matrix band of choice, and I'm sure many of you know this already, is to use a posterior sectional matrix band, but use it vertically, okay, anteriorly. Now I'll see if I can get a photo of this here, of me doing this. Now, one of the places where I saw this being demonstrated in the best way and showing both of those techniques, i.e. using a matrix band on its side vertically, such as the Garrison B100 or the Tor VM, soft one, that can be used as well, compared to using the mylar pull technique. And the nuances around that was the mini smile makeover course by Dipesh Palmer. He really went over a lot of so many cases and stunning cases after case after case. And he really goes over several indications. So, hat tip to Dipesh Palmer, amazing, talented clinician that he is. And so the tip is to use a posterior sectional matrix band vertically, and that could be, you can use many, but the B100 seems to be quite popular for that. The Garrison, I tend to use the Tor VM, which is like a Russian brand. You can get that from Incidental Limited. So I hope you enjoy that little tip. Next time when you're doing a class 4, you can just put the matrix band in, a bit of a wedge, and then this is once you build up your palatal wall. So you build up your palatal wall, and then to handle the interproximal, to get the nice contour, these curved bands can be quite good to get the right contour mesally or distally, for example. So I hope that little tip helped. Before we dive into the episode, I want to discuss one more thing that we discussed in a previous episode with Shaz Memon. We talked about personal branding for dentists. So if you haven't heard this episode already, do check it out. And my pearl then was to check out this review collecting platform for dentists called Doctify, which I quite like. I get quite a lot of views from patients, and some of my patients come from there. It's a great way to collect genuine reviews from your patients. And it looks really nice when you type in the dentist name on Google that it comes up. Now, the feedback I've had from a lot of people is that, hey, you know, I'm an associate, and when I told my principal that I want to start collecting reviews for myself, they're a bit funny about it, which it's a real shame, I think. Like, putting myself in the shoes of a principal, I get it. Like, you don't want your associate to be collecting their own reviews, because one day, what if they go, then all those reviews go with them. But that's kind of the point. The associate's self-employed, okay? But think of it as a good thing. Like, if the associate's getting good reviews and getting patients coming through the door for the associate, then they're doing their own marketing, right? It's a great thing. So I think there is a win-win to be found in there. So for those people who are still reluctant, Alex from Doctify, very kindly, he came back to me and said, hey, for anyone who listens to the Protrusive Dental podcast, he can do you guys a favor. He's willing to do 50% off for the first 4 months. That way, you can test if this is something that works for you, if you're able to collect reviews at a decent enough pace, and you will be. If you prompt your patients, they'll be happy to review you usually. So 50% off for 4 months, and so check it out. All you have to do is when you are discussing with Doctify about signing up, they'll ask you, hey, how'd you hear about us? You say, Protrusive Dental Podcast, I want the 50% off for 4 months. Then just give it a go, give it a go for 4 months, see what you think, and then the more reviews you collect, the more you get out of it, really, and then you'll be able to see the response that you get from that. So I hope that helps you guys who are sitting on the fence, and I'm hoping that even the principals who want to get Doctify for their practice will be able to benefit from that. Anyway, let's learn all about perio and occlusion. Richard Horwitz, it's great to have you on the Protrusive Dental podcast. Thank you so much for coming on.
Thank you for having me. Really grateful for you inviting me here.
No, you're a friend of mine. We went to uni. You were a few years above me at the time. And I then went on to, after qualifying, I met you on a tube. And that's when I found out, I think you were commuting to Eastman at the time to do your perio training. And then next thing you know, we're at an Indian restaurant. We're at Regency. We're having lamb chops and whatnot. So it's great to see you again over Zoom. How's lockdown been for you?
It's been good. It's been good. It's been tough, but I always like to, find the silver lining and be positive. And for me, it's been a bit of a paternity leave, as I think it has been for you as well. So it's been great to spend time with my daughter, who's 11 months, and seeing her crawl for the first time, putting herself up on bits of furniture, gnawing at bits of furniture while she's teething. So it's been really lovely, and I would never have had that. At the same time, I'm excited to go back to work. So,
I'm the same, absolutely. So the same exact journey as you, seeing the crawling development, standing, all the mischief and stuff. So it's been great. So my son's 10 months and 10 and a bit months, and Sophie's obviously 11 months. So it's I think we've shared something special over the last few months. But yes, we're both keen to go back to work. And for me, it's going to be Friday. For you, it's going to be tomorrow. For those listening, by the time this episode's published, we're hopefully going to be in the swing of things and not dressed as spacesuits anymore. I mean, I've got my hood now, so I will be dressed as a space alien. You're going to be going for a mask?
I think so, yeah. It means I can't do my designer stubble, but yeah.
Well, for those who don't know who you are, Richard, please tell us about yourself and what you do day in, day out, your specialty, and what we're going to be talking about today.
Okay. I'll start at the beginning. I'm born in London, so grew up in London, went up to Sheffield and had 5 fantastic years there. Met yourself in Sheffield. And it was a great experience. People there are so warm and friendly, and I always have a soft spot for Sheffield, and I do miss it. Friends and family in London, so I came back to London and did my foundation training. I found out what I liked and didn't like in that year. That was a really important year for me. Every time I found a case which I wasn't so sure about and wanted to refer. I wanted to see what the specialist was doing that was so special. I wanted to be able to see what could be done that I couldn't do or didn't understand how to do. So that was a great learning curve for me. I also found out what I really didn't like as well. We were chatting before. I was so happy to see your last podcast with Mark Bishop. He was a fantastic tutor. He taught me complete denture. He was a brilliant teacher, is a brilliant teacher. In those first years when I was a general dentist, I found out what I wasn't good at. And just to put this in perspective, I made a denture for a patient in a practice I was working at in Dunstable, outside of Luton. It was a great practice. I made him this denture. It was one of these Ivory style, because I was into perio. I thought I know I want to do perio and I want to make it cleansable. So I made this Ivory style denture for him.
Spoon denture.
Spoon denture, pretty much, with 2 Adams cribs. Okay. It was not something to be proud of, but I made it. Then I forgot about this denture, obviously, because I don't keep a recollection of every denture I make. I do my training at the Eastman, my 3-year specialty training in Perio. Enjoying it. It's great. In our final year, they send us out on this outreach program to work in specialist clinics in the community. And I work in this place in Bedford. And I see this patient of mine in Bedford. He recognized me. I didn't recognize the patient. And I looked at this denture and I thought, God, that is a bad denture. And I didn't say anything. Well, I just said, when did you have your denture made? Because I think you need a new one. He said, you made it for me. And I said, oh, I'm really sorry.
You said, really sorry?
I said, I'm really sorry. I think I was thinking I'm really sorry more than anything else. Yeah, so it's a bit of a long story, but it's just an anecdote to say, in finding perio as my specialty, I found things I didn't like in general dentistry. I didn't want to, I felt like I really wanted to excel in things I loved, and perio, surgery, implants were the subjects which I really wanted to master. So
that was the DF1 year where you decided in your journey?
I'd say the end of the DF1 and DF2 years. Yeah.
And did you do any shadowing of specialists? And if you don't mind me asking, how many specialists did you shadow, or for how long? Because something I advocate for young dentists DF1s is just go out there and shadow to get the maximum exposure. How was your journey in relation to shadowing and mentorship?
So I shadowed an orthodontist, endodontist, prosthodontist, periodontist. I shadowed really every specialist I could find. Anyone who I'd referred to, I'd ask if I could shadow. So I could see the journey of my patient. Patient thought I was fantastic, which I am caring and interested in them, but it's a great thing to do, to see your patient through the journey. And then you get to learn what the specialist does, which is great. And you find out, I mean, actually in Sheffield, I loved endo, and I want to be an endodontist. Oh, right. Okay. So, and then I got into foundation year and I thought, I find I'm stressing. Like, every time I do an endo, I get stressed. I get heart palpitations. I go home and I'm like, what a stressful day. Every time I was doing perio, first of all, I was thinking, God, there's so much I don't know. And even through my course, I remember the first 2 weeks was hand scaling. We did like a hand scaling masterclass. I had no idea about these hand instruments. I just didn't. There was so much to learn.
There's so many nuances, right, of every instrument that they manufacture, which angle to hold it at, which part's cutting, which part's non-cutting, the various little things which, we just think we just pick this up and we just start scraping, but really there's a way to do it. And there's, you can actually be doing a lot of damage or doing something completely ineffectively if you're doing it wrong.
Absolutely. Absolutely. And what I felt was that within my journey, there were so many new things which I just didn't know, which I was thirsty to learn about. So that's why I kind of fell on to perio. And yes, mentors are really important. I used to shadow Jonathan Lack, is a periodontist who I shadowed a lot and who encouraged me. He was teaching at the time at the Eastman and encouraged me a lot to go forth with periodontal training.
At the moment, am I right that you work in, is it Wimpole Street or Harley Street at the moment?
So I'm in Wimpole Street in Hampstead. I'm between the two, and I do lots of lecturing for the CPD department at Eastman on the aesthetic dentistry course and other courses they run there. So yeah, I
Brilliant.
enjoy it. It's good.
Excellent. We now know a little bit more about you, Richard. Let's get into the main topic for today, which is the main reason why I had this lovely pink background for you. So that it reflects Perio. I've never gone for pink before, so there we go.
I'm loving the pink. First of all, I have a lecture title which I call Thinking Pink, so that's all over it. But yeah, it's like you've got you've got the lighter stipple pink at the top of health, and then the purple disease at the bottom. I love it. It's the contrast is. I mean, my computer is too old to be able to produce a background like that. But I love it. I think I better have an
Brilliant.
update.
Thank you so much. Well, the thing I want to talk about is something that, we were talking on Instagram and stuff, something that, I'm already have an interest in. It's occlusion, it's parafunction, it's bruxism. So I know that in Perio, there are some very good long-term studies. Now, you know way more than I do about this entire subject, but I think of studies like, is it Axel or Axelson? Like those sorts of studies where they, in practice over many decades, they follow up patients and they show that, wow, we can really keep teeth with good periodontal treatment and good oral hygiene regime. So I know that Perio is quite rich in literature, and some of it is actually very good. How much is there in relation to the role of bruxism and parafunction and Perio?
So short answer, not a lot, but I'll go into it a little bit more detail. It was really the 70s where we had most of the studies which we now come to look to when we're treatment planning, when we are looking at occlusion in Perio. And occlusion is a big part of my examination. Now, various periodontists will have different levels of importance put on occlusion, and people will go with different schools of thought. I think it's incredibly important. It's a little bit of chicken and the egg, which came first when it comes to Perio or occlusion. But I think Perio is all about removing causes, controlling the etiology. And not to give the game away, whilst trauma from occlusion is not the cause of periodontal destruction, it's an exacerbating factor. And like all modifying exacerbating factors, risk factors, they need to be controlled if they can be. So it's important, and I'll talk to you when we chat more really about why I've come to that conclusion as well.
But Richard, if you want to study something like that, it's almost impossible to study. For example, if we're going to design a randomized controlled trial looking at parafunction, bruxism, there's so many variables: how long the teeth are in contact for, to what force, the size of the masseters, what kind of parafunction, is it clenching, is it excursive, and also all the myriad of inflammatory factors, the blood tests, vitamin D. There's just too many factors to be able to come up with such a study. So really, we might never know the truth, but you sound like we have some good ideas. So tell me a little bit more what your current thinking is, but I also want to know, as a periodontist, what is it that you look for in an occlusal exam, which may be different to what I look for, or maybe it might be the same?
I think it will be similar, but we'll see. I mean, I would look for guidance. I'd look for anterior guidance. I'd look for lateral excursions. I'd see if there's fremitus in any teeth. I'd look to see the incisor relationship. Is there an anterior open bite, which may have further implications on the posterior dentition? I would look for wear facets. I'd look for non-working side interferences. All these things that can influence bone loss. Because we do know, when you look at these studies, now the human ones, there aren't many, because how can you design a study? And when they do have them, the original historical ones, they're cadavers, which have had tooth wear. And then you can't really, it's difficult. So you have these hypotheses, like you have a hypothesis from Glickman, which shows that there's these zones of co-destruction. But I think when further studies were done on beagle dogs, they managed to see histologically what's going on when you apply a certain force on a tooth, and if there's periodontitis with the trauma from occlusion, or if it's in a reduced periodontium, or if it's in a healthy periodontium. So all these things are measured, and all of these are important in forming an overall idea of the role. So, and what we know from those studies is that we know that if you are a periodontally healthy dog, okay, or human, you can infer that you'll get no further periodontal destruction. You'll get no further pocket depth increase if there is no inflammation, if there's no periodontitis. What you will get is bone loss. Okay, and you'll get a widening of periodontal ligament. You'll get mobility increase, but you won't get pocket increase, and you won't get clinical attachment loss. Okay,
but surely by bone loss that infers clinical attachment loss.
No, so you because you would still have the connective tissue attachment and the junction epithelium, so you won't lose any attachment, but radiographically you'll see changes. But the relationship is bidirectional, because if you were to then, let's say this is a bruxist who doesn't have any periodontal disease, and let's say you treat them with a splint therapy, and it works really well. Once that trauma from occlusion is addressed, you will find radiographic infill of the either bony defects or widened periodontal ligament. So that is reversible if there's no inflammation. And it's the same.
Let me just home in on that. Then let me just home in on that point. So what you just suggested is that if you have someone who, through your therapy, you've managed to control their oral hygiene, you've removed any sort of factors contributing to inflammation. Yeah, and now the other piece of the jigsaw puzzle is controlling the forces, which you've suggested with a splint, for example, right?
Yeah.
And that as a package, so one without the other, you can't let the inflammation continue, but as a package, that has helped to see radiographic healing. Am I right in what I've inferred there?
So you were talking about someone with periodontal disease. This can be in someone without periodontal disease. You'll still see widening of periodontal ligament and bony defects if they have trauma from occlusion, but they won't have increased pocket depths.
And the type of bone loss that I've classically described it radiographically is a funneling.
Yes, because you get that movement within the periodontal ligament. But what you're doing, you'll stretch the periodontal, you'll stretch the attachment, you will get bone loss, but you won't get pocket reduction, unless, of course, there is inflammation. So inflammation is the key here. If there is inflammation, you will exacerbate the amount of bone loss and the progression of the periodontal disease. So we know that from both the North American studies and the Swedish and the European studies we have.
So then the next question I'll ask you is when, and also we can talk about the how, or do you even consider the role of occlusal adjustment and equilibration when you're carrying out your periodontal therapy or post-periodontal therapy to make sure that all the factors are controlled? So the forces being one factor, which may exacerbate the issue. So do you subscribe to a school of thought whereby occlusal adjustments and equilibration are part of your practice? Does that make sense?
Absolutely. So as I'm not a prosthodontist and I'm not a general dentist with occlusion as my subspecialty, I very much leave it to the experts, in a sense, to adjust the occlusion as they see fit, whether that be by taking occlusal records, mounting a semi-adjustable articulator and finding out what the consequences of adjustment is, or whether that's creating a splint, a Michigan, or any other type, is up to them in a sense. My view is it can't be left. So if I had a patient with trauma from occlusion, I would definitely discuss it with the dentist and say, I would recommend either an occlusal adjustment or a splint therapy as you see fit. Because I can guarantee if you had 10 dentists in a room, they'd all say different ways of treating trauma from occlusion. And some will be splint therapy is the only way, and some will be adjustments the only way. And each of them would think the other one, what they're suggesting is completely outrageous. So I think really my view is both work, adjusting and using a splint. So whatever at least you address it and you don't ignore the problem. I think the issue is, yes, without inflammation, it won't progress. But if you have a patient with periodontitis, they're prone to inflammation. And when you keep them a 3-monthly recall, you'll always see sometimes, okay, you've got all the pockets under 4 millimeters, you have them controlled, but something will pop up every so often. And it's important not to leave an exacerbating factor there, which can cause further deterioration. So I think it's always something that needs to be addressed. It might not be the primary cause, but it can certainly make things worse for the patient.
Brilliant. Now, when we read these texts of like Dawson, and if you subscribe to some of the what Pankey teaches, that actually in a patient who is parafunctional or exhibits bruxism, that you may be more likely to see a recession. Is there any? Because sometimes I see a patient and I know they're a known bruxist. They've got their large masters. They've got cracked teeth, and occasionally you see some teeth with recession. Now, recession is multifactorial. We know there's the biotype that's in play. We know it's their brushing habit, which is very, very heavily implicated. How much bone they have, all those sorts of things. But what do we know about recession defects stemming primarily potentially from parafunction? Is there any causal link there?
Personally, I think there's too many factors for one to pinpoint occlusion as being the cause of a recession. More often than not, it's to do with overbrushing, underbrushing, aberrant frenums, biotypes, things like that. It's a difficult one because, yes, if you have trauma from occlusion, you can get, trauma from occlusion, you won't get attachment loss. So you will only get recession if there's inflammation. Mm-hmm. So if someone is not brushing because they've got an aberrant frenum on the lower central incisor and it's really hard to clean, also that lower incisor is in fremitus. Okay, and it's just wobbling and it's highly mobile, has a lot of guidance concentrated on that one tooth, probably going to exacerbate the recession. So it definitely has a role. I don't think it's a causative factor. So it's pretty similar.
I appreciate that. Mm-hmm. Yeah, a lot of it is, and like we said right at the beginning, we will never be able to prove exactly. There's too many variables, but what we do know so far is exactly what we said. These factors are contributory. They play a role, but they're probably not the main big player here. There's other things, like inflammation, like their brushing habits we need to consider. Now, I'm very aware that some students have started to listen to my podcast and some young dentists. So just explain fremitus. What is it? How do you? We're going back to basics here. What is it? How do you look for it?
You need to look at their static occlusion, when they're biting together, what the relationship is, and when they're moving in left and right lateral excursions and anterior guidance, what movement there is on the teeth. With fremitus, if in lateral excursions their teeth are mobile and there is a heavy contact on that tooth, then that's something which you need to be aware of and mark it down. You need to mark it down because it can have an adverse impact on the health of that tooth.
I think you're right about checking fremitus in static. The simple way I like to explain to young dentists is that when people bite together, you shouldn't see their teeth move like piano keys. You know how they just flick out. Yes. And the other thing that you could do is you put your fingers on their teeth. Your index finger, your actual fingers on their teeth, and when they bite together, there might be the odd tooth where you feel excessive movement in the PDL, and that's a good way to check as well, because sometimes not always visual is by how you feel it as well.
Absolutely, that's a really good. Using a finger is really the best way. I use a finger and ask them to bite together, and that's when you'll feel the tooth move. So here, I'll just show you a couple of cases. Share screen. Advance portions. Okay, good stuff. Okay, can you see?
Yeah, beautifully. Perfect.
Here? Okay, great. So this is a patient. It's difficult to tell here, but complete wear facets on posterior dentition. This guy is 35 years old. Okay.
Wow.
Anterior open bite. Okay. Anterior.
So that's what I mean. It's good you mentioned that, because there's a lot of people who believe that by someone who has an AOB, that their posteriors are quote unquote overloaded, and therefore you may see some more periodontal destruction. So I think based on our chat so far, it may play a factor, but we also need to be mindful of inflammation and all the other bits, but we can take care of this. So it'd be interesting to see how you manage this, both in terms of the periodontal, the pink stuff, but then also the forces. So please, I'm keen.
So pink stuff, control the inflammation. Control the inflammation. You go through basics. You have your systemic phase. You check the medical history. You check the roles of diabetes. You check the roles of any medical systemic influences. You go to the initial phase, which is your non-surgical therapy. This is all things which we do in general practice, which we're all very good at. And then we have a residual pocket on this lower left 5. We have a residual pocket with bleeding. It's 8 millimeters in depth. It's not going to respond to further non-surgical therapy because of this defect. There is a local factor stopping the closure of this pocket. So what is going on? Well, it's not just the inflammation that's caused the bone loss. The bone loss has been exacerbated by a occlusal problem. So yes, I can treat the inflammation surgically, okay? But before I treat it surgically to try and regenerate this area, the occlusion needs to be addressed. Now, no amount of occlusal adjustment on a patient with an anterior open bite is going to reestablish the anterior open bite. So splint therapy is I think, personally, correct if I'm wrong, but vital in this kind of patient, unless you want to send them to the maxillofacial surgeon.
Someone's got a skeletal AOB that's quite gross like that. Then yeah, splint is a reversible way to give them a more desirable distribution of forces, which will then help the situation.
So once you have that, then we need to look at surgically what I do. I'll just show you that. So here, this case we use guided tissue regeneration. We preserve the papilla. So this little bit of papilla here we preserve and we suture back together over a graft material. This is a bovine-derived, cow-derived bone graft, and then we have a collagen membrane which is supported by the bone graft, and we suture together, and then we reduce it from an 8 millimeter pocket to a 4. And we have radiographic infill. Now, if we weren't to adjust the occlusion, or if we weren't to address the occlusion, I should say, it's very likely that any inflammation in that site will lead to further bone loss and reestablishment of the intrabony defect. So it's really important. Now, you've noticed that there is a rather bulky, but there is a composite splint holding these teeth together. Ultimately, I mean, do you want me to talk about the splinting, or when to splint?
Yeah, so I'm going to ask about splinting, but just worth mentioning for anyone watching this right now, because some people are listening, obviously, but what we can see here is Rich has shown his guided tissue regeneration very nicely. Looks very neat surgery, but you can see the wear facets, as you mentioned, quite flat on that molar and premolar, and in this case, the bony healing looks fantastic, and we see a thick composite splint at the front, which we're going to talk about in a minute, but the reason it's thick is because, trust me, if it's thin, it will break. It'll have a cohesive fracture. So it's sort of, I'm sure we learned through trial and error that these things have to be thick. You make that mistake once and you learn it. You make it as thick as you can get away with.
It's more trial and error, believe me.
Absolutely. So I mean, before we come onto the role of splinting generally for mobile teeth, where we suspect maybe occlusal or not as a role, I want to touch on why. And I'm not expecting you to know the answer to this, because I think no one knows the answer to this, but why do some people with AOBs go throughout life without any issues at all, and others have these sorts of issues? Why are some of them having cracked teeth, and while others do not? Why are some having periodontal breakdown while others are not? We just don't know. It's just one of those things. Now, I have theories, right? My theory is that those who are producing a lot of forces, I mean, yes, they have their AOB, but unless they're actually at nighttime, if they're a 17.5-minute chewer, and their teeth are touching, 17.5 minutes a day, then they're with not much force, then, the teeth aren't taking that much force. But nocturnally, during parafunction, we can produce 4 times as many forces as we can when we're aware of it. So if you tally up the fact that we have a parafunctional patient with an AOB versus a less parafunctional patient, or non-parafunctional, which are rare nowadays, with an AOB, then that may have one role. The other theory that I subscribe to is that there's perhaps a weak point. So if we look at their teeth, if we look at their periodontium, and if we look at their TMJ, for example, then one of these, they naturally have potentially a weak point, and whichever is the weakest link will suffer. So for example, if the biotype of their periodontium is hard. And you know what I mean? The type that have got exostoses that are never going to get perio because they've got surplus of bone. Even they smoke 50 a day, they don't brush, but they don't have any perio because they're almost genetically immune in a way to perio, right? So they got really fantastic periodontium, but then they're getting cracked teeth because the parafunction is actually overloading the teeth, but not overloading the threshold of perio. That's a theory. What do you think about that?
I think you hit the nail on the head when you said genetic. We know whatever health survey you look at, whether it be the Adult Dental Health Survey, the NHANES in North America, if you look at the initial studies on periodontitis in populations in Sri Lanka, it's all the same. 50% of people have periodontitis, 10% have severe periodontitis. They're roundabout. It's pretty much the same wherever you go. Now, so even in untreated populations, treated populations, Western civilization, third world, it's all the same, which means there's a massive genetic part to play. Yes, there are risk factors. You've got the smoking risk factor. You've got diabetes as a risk factor, which have strong links to periodontitis, but it's all to do with susceptibility. And this is what I tell patients all the time. I'll say that if I've diagnosed them with periodontitis, with severe periodontitis, I say, unfortunately, you are highly susceptible to something called periodontitis. Okay. Whilst 90% of people, as you said, could brush to their heart's content or could not brush to their heart's content and not have perio disease, okay, the 10%, if they just look at plaque for a second, they've got periodontal disease. Mm-hmm. And so I think shifting the blame away from you're not brushing your teeth to you're susceptible to it, so you really need to. It's a difference, and patients respond a lot better to it because they are empowered by the fact that they know that they have something which is which they are susceptible to and that can be managed. And I think I think I've gone off on a massive tangent.
No, I think what you said was great.
Coming back to the tangent, why do some people with OABs don't have that bone loss? Because 90% of individuals aren't susceptible to severe periodontal disease. If they are in that 10%, they're going to get it.
And do you find that your patients with AOBs, now this is an interesting question because I just thought of it now, it wasn't scripted or anything. So those patients with AOBs that are susceptible to perio, are they also having the same bone defects around their anterior teeth?
It depends. There are lots of factors. So if they are smokers, they'll get defects anteriorly. Because by virtue of where they hold the cigarette, you get a local vasoconstriction, as opposed, and a general as well, but more localized at the front. But or if they're mouth breathers and it's hard to brush, you get great inflammation anterior. So there's lots of factors, but it's often I'll see posterior bony defects around patients with anterior open bites. Okay.
So Richard, what I want to know, you showed that thick composite splint, obviously, and we discussed why that may be necessary. So tell us about the role of using splints. For example, some dentists may believe, and I believe from what I was taught, that actually splinting is more for patient comfort. It won't necessarily prevent them from losing their teeth or whatever. But I feel like the evidence base is Harris. Am I right? Harris? Is that a name? Okay, I don't know. These are just names I sort of remember.
I know we have a tutor at Sheffield called Harris, I'm sure.
Ian Harris, a legend. But anyway, so I believe the literature suggests that splinting has its role, but it won't. If you just splint everything, the perio won't magically stop. But what about those teeth what about those cases where you believe there's an occlusal role? Where does splints come into that? And what I mean by splint is actually sticking teeth together, not the sort of appliance to wear, which we already sort of touched on.
Yes, which can get confusing, especially when talking to about it. Where's the role? You're right. The only benefit of splinting teeth is patient comfort. However, there are other roles and when you do need to splint teeth together. One of them I showed you before. If you're doing any regenerative surgery, what you rely on is wound stability. So if you need wound stability, you mustn't have any mobility in the teeth. So for the 6 months healing, you need to splint to enable that bone to grow in the area in a undisturbed site. So it's important to splint then. Wire, composite, really whatever it is, it just has to be rigid and it has to be splinted. Now, you mentioned it needs to be a thick bit of composite so it doesn't break. That's exactly true. But also, if you're not making any occlusal adjustments and you're not removing the cause of the trauma from occlusion, that splint will break. Because if a patient's a bruxist, they will just break through it. So the cause of the trauma from occlusion needs to be adjusted there with adjustment. So there is definitely a role for occlusal adjustment in that sense, in the isolated tooth sense. I can actually show you a little example of that as well.
Yeah, please. Let's have a look. Yeah.
Okay, let's have a... Okay, so this case, another case which I use guided tissue regeneration on, but this, she was 30 years old, and she had really, it was quite localized a periodontitis to this upper left 4. Now, there are local risk factors, including a root groove and a furcation involvement. Now, fortunately, when I raised the flap and looked around the tooth, there isn't a furcation involvement yet. But there often are roots. You often have 2 roots on a premolar. You often have a root groove. But also, this patient did have a high contact on the upper left 4. That tooth was in fremitus. And also on lateral excursions, it was in group function on left lateral left lateral excursions. It was in group function. So if we're going to treat this tooth regeneratively and we're going to splint this tooth, if we splint it and don't adjust the occlusion and they're in group function, they're going to break that splint every time they chew. So that needs to be addressed. Now, whether it's addressed by an adjustment of the premolar or adding composite to the upper left canine or adding restorative material to the upper left canine to reintroduce
canine riser.
Thank you. Yeah. So yeah, if it has a canine riser, whatever it is, it's really down to the dentist to decide what's more appropriate. And I think really in this case, taking some casts, seeing how much adjustment you'd have to do compared to using a canine riser will tell you a lot. If it's just a small adjustment, then it might be just better off to make that small adjustment. If you'd have to really cut into your dentine to stop that, to stop the lateral excursion contact, then you're better off looking at a canine riser. So I think that whichever approach you take, it doesn't matter, but it needs to be done before the splinting. Now, this was just a very simple adjustment which was done, and it was splinted.
I think we can see from the clinical photo, but would you say that the cuspal inclines of this patient were very steep? Would you say?
Yeah. I mean, it's hard to tell from that photo, but yes, it was.
So it's interesting because what I think of is most people are actually in group function. As much as we think canine guidance is important, most people are actually in group function, especially if you're with any force. If you think someone's in canine guidance, you get them to press together really hard as if they're parafunctioning and then go in excursions. They are quite usually in group function. So it's good to mention here that some schools of thought suggest that actually more than anything, having it to make sure there's freedom from centric, so that when patients do have produced an excursion, that it's smooth. And if you imagine a sort of steep cuspal incline, and if patient's now moving their mandible, and it's almost like knocking and hitting against that premolar, it could be that rather than just pure group function. We will never know exactly, but these are just the sort of theories why some people with group function and why certain teeth and when. So it's all a very interesting area which we'll never really have the answers to. But I just think it's another thing to consider, that maybe it could be that tooth because of the fact it had a steep cuspal incline and there was a lack of freedom from centric, i.e. the teeth are knocking.
Yes. No, absolutely. What I'm going to be looking at is when I see this back is whenever anyone talks about occlusion, I don't know if this is just me. It will be terribly embarrassing if I do notice it. But whenever you talk about inclines and guidance, I'm doing this. I'm checking my own and I can't help it. And I'm going to look back at this video and I'm going to see myself doing it and be like, oh, but I hope you guys out there watching this are doing the same thing as me and I'm not the only crazy person. Okay. So
I think many people are.
Okay,
I think many
good.
people are, absolutely.
I can't help it. And as you said, with force, lateral excursions, like, am I group function? Am I canine guidance? Yeah, it's.
What do you think you are? What before we had this chat, what did you think you were?
I thought I was canine guidance, but I'm very aware that I've got big canine facets.
Okay, now if you actually press together really hard now, we can do it live now. You're going to press together really hard and you're going to go to one side. Do you feel your posterior teeth touching?
I don't want to admit it because I feel like I'm admitting defeat, but yes, I do.
See, it's food for thought. It's just this is why I love this area so much, because it's so fascinating. You know, no, I'm sorry. The day I broke Richard's canine guidance, I'm sorry.
It's okay. That's all right. Don't worry. I'm over it.
You're a less superior human from before we started this podcast till after this podcast.
Yeah. Now the secret's out. It's out for everyone to see.
Oh, brilliant. No, thank you for sharing that case. So I think you were going to show the splint. Did you have a photo of the splint there?
So the splint here surgically, I do it always pre-op because if it's slightly mobile before, it's going to be more mobile when in the middle of the treatment. So it's important to splint actually while you're adjusting as well, because if you splint at a different time, you might be, the tooth needs to be in the position, the final position where you don't have the interference, if that makes sense.
Yeah, it does. So you got to set them in place. Yeah, absolutely.
Yeah, set them in place before, because you might adjust it, and then if you splint it in the wrong position, which then causes you need to do further adjustment, it's a headache. So it's important to make sure you've got the tooth splinted first.
So using a metal wire splint here rather than the composite splint for those listening, basically. So yeah.
Yes, yeah, and either is as valid as the other. I mean, this one we're lucky we can hide it palatally so the patient can't see, and their occlusion is favourable in that sense. So we're able to do that.
It's very good photography, honestly, to photograph surgery like that. It's very, very good.
Oh, thank you. Thank you. So yeah, and this is the pictures with the grafting material, same grafting materials before, and we're coronally advancing the flap, bringing the tissues high, and before and after we get full radiographic infill.
How many months is the follow-up radiograph there?
That's 6 months. So
Okay.
6 months we need to leave it with no probing, no subgingival debridement in that area for 6 months. And these are predictable treatment modalities. However, they are nothing if you don't address the occlusion. So yes, a periodontist could say, well, without inflammation, occlusion has no role. Okay. And they would be right in a sense that you have the studies from Lindy Group, you have the studies also from Rochester, New York with Paulson, know that without inflammation, it's not going to progress. But that's scientific, and practically we need to look at what's the causative factor, what is the risk factor, and let's treat the risk factor. You must also treat the periodontitis, no doubt about that. That is your primary treatment aim of arresting the disease progression. But you also want to maintain, and with maintenance, you need to make sure that you are avoiding trauma from occlusion, managing it where appropriate with either adjustment or splint therapy.
Brilliant. So in this case, you would have said to the dentist, can you consider maybe a canine riser or a splint to perhaps reduce any forces, which may have a contributory role, as well as all the other things that you mentioned about their root anatomy and whatnot, in the sort of periodontal destruction of this patient?
So actually, I do it. If he did a canine riser, I'd ask him to splint as well, because not because of occlusal reasons, but because of when you've raised the flap. It's going to
no, sorry, I meant the sorry, I meant an appliance splint. yeah, sorry.
Yeah, okay, fine. This is where the confusion starts.
No. This is very normal, my friend. So look, we've discussed a few things. We've discussed some controversial topics, okay? And you know what, Richard? The truth is, some people will listen to this, right? And they will completely disagree with you. And it's true, right? Because that's the school of thought, that's the background they have. But I think as evidence-based clinicians, we have to follow the evidence, okay? And right now, it's very much strongly in the favor that occlusion and parafunction, bruxism has a role, but it's not the primary role. Now, some clinicians get very upset about this because actually they place the role of occlusion as way higher, particularly in terms of, and we can talk about this if you don't mind, is particularly in terms of implant failure. Some clinicians suggest that actually one reason why implants may be failing could be more to do with forces than any other factor. What does the evidence say? What do you think about that? on the same topic of forces and periodontal destruction, tell us about implants, because obviously they don't have any PDL, they don't have the sort of proprioception.
So mechanical failures, definitely. No doubt about it. And they need to be managed really carefully. And implants are they're a treatment modality. It's a choice. It's like a denture or like a bridge, whatever it is, you need to have the occlusion in mind. So any restoration, you need to consider the occlusion. If they're a bruxis, you need to address it before you start with your implant restorations and planning. So that's without saying. Biological failures, it's very much an inflammatory process. And I feel the general consensus is that it's an inflammatory process. You have factors which can increase the risk. I mean, when I present on periodontitis, there are so many risk factors. I mean, you've got all the ones you've got with perio, so all the systemic ones with perio, pretty much, with diabetes and smoking, etc. You've got then local factors like the implant design. Okay, you've got things like the angle from the implant platform to the contact point. So recently there was randomized control trials showing increased angle of more than 30%, higher incidence of bone loss. You've got implant surfaces, polished collars, a one-stage implant versus with soft tissue component versus a bone level. So many different things. How many times you change the abutment? That's another debate. If you keep changing the abutment, does that? So I feel, yes, occlusion has a role, but there are so many others. And I think if you focus on occlusion as the bane of all problems, I don't think it's right. But yes, with mechanical screw loosening, and then if that screw loosening or led to an abutment loosening, led to a microgap with plaque, yes, it could cause bone loss. I don't think it's occlusion straight to failure of the implant. Sometimes you get, sorry, I'm going on. Sometimes you get an initial failure through overloading it too early. That's a different scenario in itself.
I see your point there, and I think the answer is somewhere where there are too many unknowns. But what's good practice at the moment is not to look for everything, your patient as a whole, all the factors involved, and like you said, it definitely has a huge definite role in mechanical failure, screw loosenings and whatnot, whereas the biological, from what we understand at the moment, is mostly inflammatory. And that's, it's cool that you have that stance, and I respect it. And that is the main stance, that is the body at the moment. That's the evidence body at the moment, and any periodontist would back you up. But, there are people who are not guided by the evidence and have these theories, and that's all there is. But we have to sort of, everything is in balance, and you have to reflect on it. I mean,
evidence is based on testing theories. So it's not a bad thing to have different theories and different opinions. I think that's what drives us and makes us better dentists. So that's fine. But that's why I say that checking the occlusion as part of your periodontal examination is a must. It's something which is often left. And it is really important and valid. Just because I don't feel it's the primary cause of periodontitis doesn't mean to say I find it any less important in progression of periodontitis. And it has to be addressed, especially when I show you those cases where they were in part exacerbated by a trauma from occlusion. If you don't treat the trauma from occlusion when it's exacerbated a periodontal problem, it's never going to be treated. So it's really important.
Thank you so much, Richard, for coming on. If anyone wants to reach out to you, because I know you do a bit of teaching at the Eastman, maybe they work locally to you and they want to refer you a patient, how can they reach out to you?
That's very kind. Thank you. So reach out to me. Well, I have an Instagram account, London Periodontist. My email, rh@richardhorwitz.co.uk. And if there's any questions on trauma from occlusion or anything else, I'm happy to help.
Rich is a very helpful guy. If you ever message him, he'll always be willing to help you out. So I would, young dentists who want maybe some mentorship on perio, implant, that sort of stuff, Rich is a great guy to reach out to. So, buddy, I'm wary of the fact that Sophie will probably be waking up soon, and so will Ishan. So thank you so much for coming on, mate. It was absolute pleasure discussing something very controversial with you. So there we are. We covered lots of different points, and essentially, it is something that I hope most of us knew already, that as far as we know, a bad bite or occlusion or even parafunction just by itself won't cause perio. But for that susceptible patient, it's one more aggravating factor that can lead to trauma, that can exacerbate existing plaque-induced periodontal disease. So I hope you found that interesting. Thank you so much, Richard, for coming and sharing all that specialist information with us. I'm so sorry, Richard, for ruining your canine guidance, okay? That one's on me. I apologize, okay? Thank you so much for listening all the way to the end, guys, and I'll catch you in the next episode.